I would like to welcome you all at the 26th Biennial International Pediatric Conference organized by PPA. First of all, we would like to start the session by the name of Almighty Allah. So, for the recitation and for the audio play of some verses of Holy Quran, kindly. Special announcement that I would like to do. There is a award for the Young Research Award, and it will be given for any one of the person, and that will be decided by the panelist. And there is an award of cash prize of 10,000 rupees and a shield. And the other announcement is that there is a plenary in Hall A at 11 p.m. and also the tea will be served 11 a.m. and also the tea will be at the pool side. So I would like to thank all of you to be a very nice audience, and starting the session, first of all, I would like to invite the panelists, and the panelists for today I would like to invite Professor Khurshid Abbasi. He is a professor of pediatrics at Gambut Institute of Medical Sciences. He is head of department pediatrics, and also he is the general secretary of PPA-SIN. And sir, please welcome on stage. Take your seat, sir, please. And the next panelist is Professor Jalal Akbar. He is Associate Professor at Bakai Institute of Medical and Health Sciences. He is the Chairman of Pediatric Department, and he's also ex-President of PPA-SIN. Sir, please, take your seat. Professor of Pediatrics. Ex-President. Okay, sir. VPA Center, yes, sir. Sorry for the inconvenience. And the next panelist is Professor Dr. Prem Chand. He is Assistant Professor at AKU Neurology Department, and also he is the in charge at Neurology Department. His special interest is in epilepsy, and he's a section head at Neurology. Please, sir, take your seat. Last but not the least, I would like to invite Dr. Shazia Sumro. She is an emerging neurologist, and she is assistant professor at Pediatric Neurology Department at National Institute of Child Health. Please, ma'am, take your seat. So starting the session, I would like and request the panelists to introduce the speakers. And the first speaker for today is Dr. Shazia.
Yes, thank you very much, Dr. Sadaf. Actually, we have a very talented panel of speakers. And as Dr. Shazia Kulsum is the first speaker, she is the pioneer of the Neurology Department at National Institute of Child Health. And she is the active member of Pakistan Pediatric Association. And she is actively involved in the research and training activities at NICH, and currently working as head of department at Neurology unit of NICH. So her today's topic is myasthenia gravis evaluation to management in children. So please welcome Dr. Shazia.
Thank you so much everyone and Dr. Shazia Subro and everybody over here. इतना अच्छा इंट्रोडक्शन करवाने के लिए अभी तो मैं तिफले मुक्तब हूँ और सीख रही हूँ और स्पेशली दिस इज़ रियली डिफ़िकल्ट फॉर मी टू शेयर अ स्टेज विथ माय टीचर्स माय मेंटोर्स फ्रॉम whom I learned a basic of pediatric neurology. So thank you so much. Okay, pointer से change नहीं होगा. So I would be talking about myasthenia gravis in childhood. These are the entrance view of my Department of Pediatric Neurology at National Institute of Child Health, and the department is working for more than past 2 years. This is my disclosure statement, and in upcoming slides I would like to talk about these highlights of myasthenia gravis in childhood. If I say what is the definition of myasthenia gravis, what is the introduction of myasthenia gravis, the most commonest type of myasthenia gravis is an autoimmune disorder and in which the autoantibodies are directed against the neuromuscular synaptic junctions which impair the synaptic transmission and which leads to the fatigue and lethargy. What is the epidemiology of myasthenia gravis? Obviously, the data is from the West and there is no local data particularly related to the pediatric population about this problem. So it's a rare disorder in which the incidence is estimated about 1 to 5 per million persons. And the estimated incidence of commonest type of myasthenia gravis, which is autoimmune origin, is about 1.2 per million persons. And it was found in a research that about all the myasthenia gravis, 10 to 15% of the myasthenia is started in a childhood. So whole of the myasthenia cases, 10 to 15% belongs to the pediatric population. And the most highest proportion of myasthenia was found in an Asian population, which is followed by a African population. So how do myasthenia gravis present? So myasthenia gravis has a 2 different clinical presentation. It can be a localized myasthenia gravis, which is called as a ocular myasthenia gravis, or it can be a generalized myasthenia gravis. So it was found that around 10 to 35% of the myasthenia gravis was found to be localized with the ocular myasthenia gravis in childhood. And the commonest clinical manifestation of localized myasthenia gravis, the ocular myasthenia gravis, is ptosis, strabismus, diplopia, the paralysis of extraocular muscles. And I want to share that those children who do present with the ptosis, about 0.81% have a positive myasthenia gravis. So the ptosis, if present, it needs an evaluation for myasthenia gravis. What is generalized myasthenia gravis? So along with the ocular manifestation, if the skeletal muscles are involved, any group of skeletal muscle is involved, it is called as a generalized myasthenia gravis, and usually the involvement is of a proximal muscle, the girdle muscles, the hip girdle muscle, the shoulder girdle muscles. And what is the commonest presentation, clinical presentation of myasthenia gravis? So myasthenia gravis, if it is generalized, it do have a present ocular manifestations, which is diplopia, which is strabismus, double vision, which is and the generalized manifestations are diurnal variation, measurable fatigue, change in the quality of voice. It may lead to the difficulty in swallowing, sucking, and the most troublesome presentation in myasthenia gravis is, which is an emergency situation when there is the involvement of diaphragm, which lead to the respiratory arrest. So these two were the clinical presentation, either the ocular myasthenia gravis, either the generalized myasthenia gravis. What are the types of myasthenia gravis? It depends on the etiology of myasthenia gravis. So the myasthenia gravis is broadly divided into 3 types, and the one of them type is a transient neonatal myasthenia gravis. So the neonatal myasthenia gravis occurs into a neonates, the newborns of the myasthenic mothers, and those mothers who is having an autoimmune type of myasthenia gravis. Around 5 to 30% of the infants born to the myasthenic mother, they have a transient neonatal myasthenia gravis. And the important thing about this type of myasthenia is that the symptoms resolve when the antibodies are cleared from the neonate's blood circulation. The symptoms will resolve. So another type of myasthenia gravis, which is also present in an early age, is called as a congenital myasthenia syndrome. The congenital myasthenia syndrome is basically a group of different genetic disorders where the vast number of genes have been identified for these type of clinical presentation. And the most important thing is that the congenital myasthenia syndrome is a permanent disorder, and it is not of autoimmune origin. So the presentation in infants, in a neonate of congenital myasthenia syndrome is like a floppy infant. It presents like a paucity of movement, difficulty in sucking, the shrilled cry, the frequent choking and apneic spells, breathing difficulty. So it do present like a myopathy, certain inborn error of metabolism as a floppy infant. And the one thing I want to share with the audience that it is very important to know about the etiology of congenital myasthenia syndrome, because it is really clinically difficult to differentiate between a juvenile myasthenia gravis, which is autoimmune origin, and congenital myasthenia syndrome. Why the differentiation between idiopathic juvenile myasthenia gravis and congenital myasthenia syndrome is important. It is important to decide about the treatment. It is important to decide about the prognosis. And it's really difficult to differentiate between two if we do not know the genetic cause or if the patient is seronegative. When the workup for the juvenile myasthenia gravis is negative, it's really difficult. So it was found that more than 24 different genetic mutation is responsible for the cause of congenital myasthenia syndrome. And these are the commonest genes which are highlighted in the last line. You pointed me, children. So these are the commonest genes which are involved in a congenital myasthenia syndrome. Please escuche. Okay. Okay, so it's very light. I tried to simplify this difficult slide, which is related to congenital myasthenia syndrome. And in a congenital myasthenia syndrome, the defect may be a synaptic, a presynaptic, synaptic, postsynaptic, or defect in the end plate development of motor membrane. So the most commonest type of congenital myasthenia syndrome is postsynaptic, which is around 51.4%, and this is followed by a defect in end plate development, which is 25%. And here in this slide, I want to emphasize again, it is very important to know the genetic defect of congenital myasthenia syndrome, because the therapeutic option, the conventional therapy which we do offer in a juvenile myasthenia gravis may worsen few of the congenital myasthenia syndrome, like the slow channel variety may be clinically worsened if we offer a conventional therapy, which is acetylcholinesterase inhibitor. This is the detail highlight and busy slide, but I think the clinically and practically the previous slide is most important. This is the most commonest type. of myasthenia gravis, जो कि देखी जाती है, practice की जाती है, treat की जाती है, but other forms also do exist. So it is present in a younger children. The age range is below 18 years of age, and it is autoimmune origin. The autoantibodies are directed against the neuromuscular membrane. The clinical features are ophthalmoplegia and the difficulty in sucking, the diurnal variation as discussed already. So the myasthenia gravis is autoimmune origin, and the serological profile shows a different type of antibodies, but one of the type of antibodies, which is called as a muscle-specific kinase, it was found that if this antibody is positive, it is associated with more acute presentation, and the commonest presentation is respiratory failure if it is positive for the MuSK antibodies. So the respiratory crisis is the commonest presentation of this type of serological positive myasthenia gravis. And this is the basic slide which each and every student of MBBS do understand in their early year of education, and as a doctor we do know about the basic defect of the myasthenia gravis. So this is the normal. The nerve ending contain the acetylcholine receptor vesicles. They release, they bound to the receptor side, and there is a muscle contraction. But what happened in a myasthenia gravis? There is the nerve ending contain the acetylcholine. They do release the acetylcholine, but there is a defect in the binding of acetylcholine due to presence of these antibodies at the receptor site. So when there is a defect, it leads to the absence of synaptic transmission and the muscle fatigue. So if the child present to you with the myasthenia gravis, your diagnosis is myasthenia gravis, how to evaluate it, what is the investigations for which you want to proceed. So it's the serological investigations. So anti-acetylcholine antibodies were found to be positive in 70 to 74% of patients with generalized myasthenia gravis, and 40 to 60% in ocular myasthenia gravis. So antibodies most likely to be positive in generalized form. But if the antibodies are negative, they do not exclude the myasthenia gravis. And the positivity of anti-muscle specific kinase antibodies is variable. And it's also related on ethnicity and the region. And it was found that if the antibodies are negative in the early manifestation, they may be positive later on, after the years of initial clinical manifestations. And if the patient from a positive antibodies is converted into a negative antibody status, that indicates a remission. And it was also observed that the negative antibody status is having a most chance of remission. I hope I explained it well. In an older day, when I was in a training, we used to rely on a different test other than a serological profile. So among the other available investigations, the electrophysiological test is also one of the diagnostic clue for myasthenia, which shows a characteristic typical electrodecremental response. And among the conventional electrophysiological testing, the most advanced, which the 95% sensitivity, is single fiber electromyography, but it is technically difficult in the children. The pharmacological diagnosis, the most favorite of test when I was in a training, and it was done as a Tanslon test, hydrophonium test in ICU setup. But nowadays, due to availability of commercially serological profile, it cannot be done in a routine basis to diagnose the myasthenia gravis. And this hydrophonium is basically a short-acting acetylcholinesterase inhibitor, and after the injection of it, the few changes in the fatigable position of the muscle can be observed, which which is usually ptosis, ophthalmoplegia, or dysarthria. So it's important to know the myasthenia gravis in childhood because the management is a bit different from an adult population. Why it is different? Because the list of differential diagnosis which we kept for a childhood myasthenia gravis is different from adult myasthenia gravis, and the most of the time the myasthenia gravis in childhood goes into a remission, and of course, if we initiate the therapies early, the outcome is better, which is the functional outcome and the psychosocial outcome. So the therapies is broadly divided into 3 categories, which is the symptomatic type, which is pharmacotherapy, the immunosuppressant therapy, and the surgical therapy, thymectomy. The decision to start about the treatment for myasthenia gravis is very important decision, and this is a very important and easy chart which is available, which is called as a myasthenia gravis activity of daily living score, in which we categorize a certain clinical criteria, and it has a scoring from 0 to 3. Oh, I'm sorry, I know that we are running short of time. I just want to wind it up. So symptomatic is paradigmatic, mean chronic immunosuppression is prednisolone is the drug of first choice, thereafter the others, and rapid immunomodulatory is plasmapheresis, IVIG, and the surgery. Just give me 2 minutes so I can wind it up. This flow chart is very important, which I want to share with the audience. So in case of juvenile myasthenia gravis, if the symptoms are mild, start acetylcholine esterase. If there is a clinical improvement, wean off acetylcholine esterase and continue corticosteroid as a first-line immunosuppressive therapy to the lowest possible dose till the remission is occurred. Right? But if there is no clinical improvement, add on steroids, clinical improvement, follow this algorithm. If there is no clinical improvement, add on the second-line immunosuppressant. Clinical improvement, continue azathioprine and wean off paradigmine and gradually reduce corticosteroid. If no improvement after the second-line immunosuppressant, change to other immunosuppressant options. Right? And in case of a moderate to severe type of myasthenia gravis, start acetylcholine esterase and steroids simultaneously, and then follow the algorithm. This is very important and practical slide. Do I have a time? No? Okay, the last one. So थाइमेक्टमी के बारे में बहुत ज़्यादा मिथ्स हैं, क्या होता है क्या नहीं होता है, बट देयर आर क्लियर कंसेंसस गाइडलाइन अबाउट द थाइमेक्टमी. सो थाइमिक हाइपरप्लेजिया इज कॉमन, बट थाइमोमा इज नॉट कॉमन इन myasthenia gravis, and all the children with myasthenia gravis do have evaluation for thymic hyperplasia or thymoma, and the thymectomy is considered in those patients who are antibody positive, who have a moderate to severe clinical presentation, and it's better to be done within the first 2 years of clinical presentation, and there is no role of thymectomy in case of anti-MuSK positive myasthenia gravis. This is very important to know. So antibody positive, moderate to severe symptoms during the first 2 years of clinical presentation, while the mild variety do not need a thymectomy because of the highest percentage goes into a remission. This was the surgical treatment. So just the brief last few words about the myasthenia gravis in childhood. So corticosteroids are first-line immunosuppressant, and it was found that the rituximab, which is the immunosuppressant type of therapy, is better therapy for the MuSK positive patient. And IVIG and plasmapheresis is reserved for the severe symptoms but can be used as a long-term maintenance therapy. And in the consensus guideline, it was found that the plasmapheresis is more superior to IVIG to resolve the acute symptoms of myasthenic crisis. And this was the recently published guideline in 2020. So this is what I want to highlight. Thank you so much.
थैंक यू सो मच डॉक्टर शाजिया। वो एक अब्र का टुकड़ा कहाँ बरसे, सारा दश्त प्यासा दिखाई देता है। बेसिकली वी हैव टू बी वेरी रिस्ट्रिक्टेड एंड फॉलो द टाइम गाइडलाइन, एंड आई हैव बीन रिक्वेस्टेड बाय द रेस्पेक्टेड पैनलिस्ट टू इंश्योर दैट एवरी स्पीकर गेट्स his or her speech finished in time. So for inviting the next speaker, I would like Professor Dr. Khurshid Abbasi to introduce Professor Tipu Sultan. Sir, kindly.
Thank you, Dr.
Thank you, sir.
Sadaf. First of all, I'd like to thank Dr. Shazia for a brilliant presentation on the myasthenia gravis. The next important speaker is Dr. Tipu Sultan. He's professor and he has graduated from the Allama Iqbal Medical College in 1997, did his FCPS in 2004 and second fellowship in 2006 from the Glasgow. Then he went on to complete his master's in epilepsy from Leeds, UK. Currently working as head of the Department of Peads Neurology at the Institute of Child Health at Children's Hospital, Lahore. He is the founding member of Pakistan Pediatric Association Neurology Expert Group and currently is the Secretary General of the Child Neurology Group of PPA. His topic is epilepsy and he is going to talk on knowledge and practice for the next 20 minutes. Thank you.
Thank you, sir, for your kind words and introduction. And thank you, Pakistan Pediatric Association, for giving us the opportunity to speak. The topic I selected was perhaps one of the commonest topic, and the theme out of the topic is epilepsy, knowledge to practice. Reason being, I strongly believe we pediatricians or maybe pediatric neurologists, we all know a lot about epilepsy, anti-epileptic drugs, its management, and of course, side effects. But once it comes to the actual management of an individual patient, it's really challenging. Because it's not mere prescription of phenobarbital or phenytoin or maybe the valproate sodium or the newer ones like levetiracetam, but it's the whole child as a whole in combination with some comorbid condition, etc., like behavioral changes, autism, ADHD, and some other systemic disorders. So, like Shazia started her talk with the first slide of the department, same here. This picture was taken during one of the International Epilepsy Day, and the purple color balloons in fact represents the purple color which is associated with the purple color for purple day for the advocacy in general public about the epilepsy. So I'll quickly skip some of the initial slides of introduction and the knowledge about the epilepsy. Rather, my focus would be more towards the practice. So that was the main theme or agenda I have in mind. Instead of just putting too many theoretical slides, would like to share some clinical experience. So we all know what exactly epilepsy is. We all know its epidemiology, its natural history, its prognosis, how one can describe a seizure. So per se, seizure is an abnormal, excessive, hypersynchronous neuronal discharge. And in contrast with the movement, so start of a good management or a start of practical skill actually begins from the correct diagnosis. So I'm sure many of the pediatric residents or maybe a pediatric fellow are sitting here. So if you are not correct from the start about the diagnosis, are unable to differentiate between a movement disorder or a seizure, then of course the ultimate achievement or ultimate remission, which is seizure freedom, might not be achievable. So what exactly is this? It's not seizure. It's a movement disorders. It's familial chorea. But we have seen over the years, many of the children with some sort of movement disorders, they are being prescribed with many different anti-epileptic drugs. So, same is the case with epilepsy. The commonest or easiest definition for the residents is 2 or more unprovoked seizures 24 hours apart. This is the EEG representation of the same. Etiology is a bit different and changed over the years. In resource-limited countries, it's the injury to the brain. So whatever the underlying reason, whether it's hypoxic ischemic encephalopathy, there are many neonatologists sitting here in the audience. So whether it's in utero, difficult labor, asphyxia at birth, early onset sepsis, late onset sepsis, hemorrhagic disease of the newborn, or torch infections. And the new entry in this list in countries like ours is the genetics. So a genetic disorder may be simple neurodegenerative disorder, though they are not simple per se. It could be a metabolic disorder, or because of the advent in the good imaging techniques, the malformations of brain. The commonest reason for idiopathic intellectual disability, learning disorder, and seizure or epilepsy at some stage is generally because of genetics. So, started from 7 minutes. So the clinical manifestation is generally loss of consciousness, posture control, automatism, and many systemic presentations. This is the reason behind the focal seizure when discharges come from one lobe, generalized seizure when it comes from the central part, and the central secondary generalization. I'll quickly some of the initial slides because slip has been given to me for the time's constraint. So I'll skip these initial slides more quickly rather now. This was the older version of the epilepsy classification, which was developed by ILAE in 1989. So, which was a bit easy for us still. However, it's important for the young pediatricians, for the residents and the fellows, that it's the newer classification. And luckily, this classification was developed by one of my mentor from Glasgow, and Professor Zubairi is right now is in Pakistan, rather he is in Karachi now, and today he will fly back to Glasgow. So this new classification was developed by ILAE in 2017. The previous slide shows the relatively shorter version, and it's the extended version. But the change in this classification or in this new description is the involvement of many of the etiological factors, which includes, as I have mentioned about the structural metabolic infections, some of the comorbid conditions, and ultimately combination of all these seizure types, its etiological factors, EEG manifestations, clinical manifestations, comorbid conditions led to a condition or association called epilepsy syndrome. So what exactly epilepsy syndromes are? These are the conditions on the basis of a combo between seizure type, neurological finding, etiology, and EEG features. So one of the commonest neonatal or early infantile epilepsy syndrome is infantile spasm. So perhaps it is not only the commonest, but most of the challenging in the neonatal units, in the pediatric departments, mislabeled, mistaken, and delayed in diagnosis. Now, in the recent literature, in the recent data, it has been proven the later the diagnosis, the delay in the diagnosis led to significant developmental delay, because the new definitions, the new classifications, the new understanding led us think about the ongoing deterioration and alteration in the networking of the brain. So that's why they have been called and labeled as epileptic encephalopathies. So this new definition, this new classification divided into focal and generalized. The word partial have been replaced with the focal. So generalized are divided further into absence seizure, which are in fact non-motor component, and motor seizures like myoclonic seizure. So because of the shortage in time, I might not be able to show you some of the really interesting and important videos, but I'm sure you would have some idea about these from the few second clips. So these are motor myoclonic seizures, and this is again a motor myoclonic atonic seizures. So all these are classified under the heading of generalized seizures. Generalized, as usual, it's quite easy and the same as were in the older classification as in this newer classification. The age is generally not very much important in terms for the general pediatricians to diagnose. However, really important for the pediatric neurologist, for the prognosis for the epilepsy syndrome. So per se, the diagnosis of epilepsy is clinical. Age is not part and parcel for diagnosis of epilepsy. It's always the history and the clinical examination, and one should remember all these clinical points for the diagnosis of epilepsy. However, once you confirm a diagnosis of epilepsy, then it's really important to discuss, to counsel the family about its long-term prognosis, and in that case, EEG is quite helpful. So like many other disorders, clinical examination is always very important. If you examine a child thoroughly and found some neurocutaneous manifestation, then it's really important to counsel according to those clinical lesions, whether it's neurofibromatosis 1, 2, or Strudge-Weber, etc. Generally, investigations are not required per se. However, in case of neonatal practice, the seizures may be secondary to hypoglycemia, hypocalcemia. In that case, they might be helpful, or in a relatively older children, uremic encephalopathy, hepatic encephalopathy, etc. However, the two most important investigations for diagnosis of epilepsy is EEG and imaging, but they have specific indications. Once you have some calcification in the brain, or mesial temporal sclerosis, or agenesis corpus callosum. So recently, some of the genes have been diagnosed, and some genes have relatively good prognosis and some have relatively bad prognosis. This is the list of some of the differential diagnoses, so one should always keep the list of differential under his or her mind. So यहाँ पे तो कर रही है, ये तो अब आपने चेक करना है कि यहाँ पे क्यों नहीं हो रही. वो स्लाइड नहीं चेंज हो रही वहाँ पे, यहाँ पे तो हो रही है. हाँ अच्छा जी. तो आई थिंक हम क्लासिफिकेशन पे खड़े हो गए थे, शायद उसके ऊपर जैसे सर ने फरमाया कि टाइम आउट हो गया. अब वीडियोस तो थैंक यू सर, आपने नोट करा दिया, वरना मैं तो इधर बोले जा रहा था, नोबडी वाज. हाँ, तो ये दिस वाज द स्लाइड जहाँ पे हम कर गए थे. अब मैं इसको क्विकली थ्रैश करता हूँ कि ये सारी वीडियोस दिखाने का तो शायद अब टाइम नहीं है मेरे पास, तो दिखा दें. अच्छा मैडम, सर अब ज़माना तो जमहूरियत का वैसे है, और आपको पता है इस वक्त अवाम किसके साथ है. तो देखिए, फोकल सीजर ये बिहेवियरल अरेस्ट है. अब बताने का ये टॉपिक जो मेरे जहन में था वो ये था कि हम बताएं एक दूसरे को कि व्हाट पीपल थिंक अबाउट दीज सीजर एंड व्हाट एग्जैक्टली दे आर. बिहेवियरल अरेस्ट, अवेयर, मोटर, क्लोनिक, ये सब नई क्लासिफिकेशन जो ILA की बनी है उसके अंदर की ये वीडियोस हैं, और हमने इसको बताने की और सिखाने की कोशिश की है कि कैसे ये these two young girls are actually doing their homework with the moms and have some kind of behavioral arrest and some absence जो कि इनकी माओ ने नोट किया. और you can see these seizure, these are the motor myoclonic and these are myoclonic atonic. The loss of tone led to sudden fall in these young girls. Look at this. This is. तो ये जनरलाइज सीजर तो इजी हैं टू डायग्नोज. हम अब इसको क्विकली थ्रैश कर लेते हैं. एग्जामिनेशन बहुत ज़रूरी है. इन्वेस्टिगेशन की हमने बात कर ली, जीन्स की हमने बात कर ली. जीन्स आर रियली इंपॉर्टेंट बट अनफॉर्चुनेटली नॉट इजीली अवेलेबल इन पाकिस्तान. दिस इज द लिस्ट ऑफ डिफरेंशियल डायग्नोसिस. दिस इज परहैप्स द इंपॉर्टेंट स्लाइड. वन शुड रिमेंबर दीज पॉइंट्स फॉर द क्लिनिकल डायग्नोसिस ऑफ एपिलेप्सी. जनरली सीजर आर रिकरेंट, एपिसोडिक, stereotype. It's not really common to have absence seizure in the morning and partial seizure or focal seizure in the afternoon. Generally they lasted for a few minutes except status epilepticus. Post-ictal exhaustion, frothing, tongue bite, and continence are usually associations. So seizure और syndromes मैंने अभी थोड़ी देर पहले बात कर ली है. Epilepsy syndrome में West syndrome का मैंने जिक्र किया है. The commonest, but the good thing is combination of oral steroid along with antacids and the recently registered and available Vagabat in Pakistan have changed the landscape in the management of these infantile spasm, whether it's associated with tuberous sclerosis complex or without. And this is the classic EEG which is called hips arrhythmia. I'm sure some of the pediatric residents who are going to sit in the talks is the most common EEG being asked in the examination. So one should not miss. In the coming slides, I would like to show you the difference between infantile spasm and the benign sleep myoclonus, which is commonly mistakenly treated as epilepsy. Isko main skip karunga. This is another common syndrome generally present in girls, teenage girls. The EEG is most diagnosis. Challenge for the pediatrician is clinically normal children, radiologically normal children. It's only the EEG which gives you some clue about the diagnosis of this juvenile myoclonic epilepsy. The literature says, the book says, early morning myoclonic jerks or fall of the glass or maybe the toothbrush from the young children. The good thing is it's nicely responded to valproate sodium or maybe the levetiracetam. However, in majority of children, this is a lifelong drug. So again, as I mentioned you about the correct diagnosis, abnormal movements, tremors should not be taken and confused with seizure or epilepsy. They might be associated with epilepsy. So one of the commonest side effect of valproate sodium is tremors. So one should not mix the side effect of the drug or the initial presentation. Conversions should not be taken with these epilepsies. वो मेरे साथ फिर आ गई हैं. आई थिंक अब तीसरी स्लिप दे दें मैडम. 2 स्लिप्स अभी तक आ चुकी हैं, अब तीसरी का मैं इंतजार कर रहा हूँ. दे दें मैडम, कितने मिनट वाली? अच्छा, तो आई थिंक अब ये सूडो सीजर है, इसकी हमने बात कर ली. अब हम लास्ट कंपोनेंट पे आ रहे हैं, एपिलेप्सी की मैनेजमेंट पे. One should treat 2 or more seizures. This is the standard message, standard teaching. However, one should not wait for the second status. If EEG is positive like in JME, if clinically abnormal examination or abnormal radiology, for instance, degenerative disorder where you find some demyelination, then one should not wait for another status or epilepsy. These are the options: anti-epileptic drugs, vagal nerve stimulation, epilepsy surgery, ketogenic diet. But the good thing is 70% roughly children, they nicely responded to anti-epileptic drugs and become drug-free and seizure-free. However, one should always consider all these points, and the most important, the last point is the cost of the treatment. अब मैं साथ साथ इधर भी ध्यान रखूंगा कि ये और ये सेम होनी चाहिए, सेम पेज पे होना चाहिए ना. ये आजकल सेम पेज का लफ्ज़ भी खासा यूज़ होता है, तो हम इस वक्त सेम पेज पे हैं. सो बिफोर द स्टार्ट ऑफ द ट्रीटमेंट इट्स रियली इंपॉर्टेंट कि आप 100% श्योर हों कि वी आर ट्रीटिंग विद एपिलेप्सी. लुक एट दिस गर्ल, when she came in one of our OPD or was already on 4 drugs. So instead of putting her to another drug, I just requested for the video clip of those seizures. And look at these seizures for which she have been prescribed by a local practitioner with 4 anti-epileptic drugs, in contrast with which is clearly generalized tonic-clonic seizure. So the message behind all these slides is witness is important. And these days, in the presence of millions of mobile phones, almost in everybody's pocket, smartphones, one should always ask for the video recording of these seizures. Basic principle is go slow and go low. And selection is again very important criteria, as I mentioned you to begin with. So long-term safety, tolerability, seizure quality of life. Quality of life पे यहाँ मैं 1 मिनट with the permission of the moderator and the chair both सिर्फ 1 मिनट लूँगा. A drug might be very good for the control of seizure. For instance, valproate sodium. A 12-year-old girl weight for instance 40 or 50 kilogram, हम उसको valproate पे शुरू कर दें, सीजर कंट्रोल हो गए, लेकिन 2 साल बाद 3 साल बाद वो 70 किलो की हो गई, 60 किलो की हो गई, फिट्स तो कंट्रोल हो गया, लेकिन हमने उसकी क्वालिटी ऑफ लाइफ को अफेक्ट कर दिया. अब लुक एट दिस यंग बॉय, सिर्फ 6 साल पे इसका 50 किलो वजन है. अब अगर इसको valproate सोडियम शुरू कर दी जाए, दैट माइट नॉट बी अ गुड सर्विस फॉर हिज a long-term quality of life. So this is perhaps one of the important consideration in the management of seizure. I will not go into the details, the history. These are some of the newer anti-epileptic drugs available in Pakistan. Some of these relatively unusual things which might be taken as a last resort in case of epilepsy. These are IVIG and plasmapheresis, steroid, methylprednisolone. For the drug of choice for the focal seizure is carbamazepine, for the generalized is valproate, for absence is valproate along with lamotrigine. Tuberous sclerosis recently available is vigabatrin. JME की मैंने बात कर ली है. New modalities, यहाँ पे लगाऊंगा 1 मिनट सिर्फ. Ketogenic diet and CBD oil. These two are available in Pakistan's keto clinic is being successfully conducted by Professor Shahnaz at AKU and in Multan children, and recently for the past almost 2 years we started keto clinic in Lahore Children's Hospital. So this is the book we generally for the patient education at the start of. So drug resistant epilepsy and benign, ये मैंने जो अभी बात की है कि one should not confuse these subtle movements, benign sleep myoclonus with epilepsy, और इसके लिए किसी एंटी एपिलेप्टिक ड्रग की ज़रूरत नहीं होती. इन तमाम दवाइयों के साइड इफ़ेक्ट्स होते हैं. इंट्रैक्टेबल के साथ इंजरी होती है. साइड इफेक्ट में पर्टिकुलरली कॉमनेस्ट हमारी ड्रग विच इज़ valproate sodium, significant thrombocytopenia is the most common side effect along with hair fall and drug eruption in many drugs. Discontinuation of drug is anti-epileptic drug is very important, maybe generally after 2 to 5 years, and status epilepticus at home. Whenever you diagnose a child with status epilepsy, you should always teach and counsel about the status epilepticus because the management start at home. Whether it's diazepam suppository or intranasal midazolam or maybe intramuscular midazolam, guideline or teaching is really important. Is some of the new thing हम ख़त्म कर देते हैं और conclude करते हैं. Epilepsy is the commonest pediatric neurological disorder and the perhaps commonest condition for the pediatricians to treat, to deal, and a correct knowledge, practical knowledge is really important for the control of seizure. This is the University of Child Health Sciences, Children's Hospital, Lahore. Thank you very much.
That human mind and parachute are same and they only function when they are open. So sir, thank you so much for opening our minds, and now I would request Professor Jalal Akbar to introduce our next speaker, and for that I would like to say something. सुना है लोग उसे आंख भर के देखते हैं तो उसके शहर में कुछ दिन ठहर के देखते हैं. अगर वो बोले तो बातों से फूल झड़ते हैं. अगर ये बात है तो बात करके देखते हैं. जी.
Thank you. I think for me, Professor Shahnaz Ibrahim need no introduction, but since this is a formality, so it's a great honor for me to introduce Professor Shahnaz Ibrahim. She is the professor of Peads Neurology at AKU and the president of Pediatric Neurology chapter of Pakistan. She is one of the pioneers of pediatric neurology in our country, trained many young neurologist, वो neonatologist और nephrologist इतने सारे हो गए, neurologist which are working both inside and outside Pakistan, and she started the first ketogenic program published in a high index journal, and she carries an experience of more than 20 years. Madam, please take your stage.
Okay. Assalamu alaikum ji, and thank you very much for the very kind introduction. As usual, this podium is higher than I am. It's always the case. So I won't look at the slides over there, I'll look at it over here. Before I start, Honorable Chair and co-chairs, please tell me how much time do I have?
20 minutes.
I do have 20 minutes?
20 minutes.
Okay, so I'm going to set the timer for myself. So before I start getting purchase. Okay, so the topic for today that I was given was approach to a child with who is floppy basically, and an infant. So without much ado, I will go forward. Basically, our objectives are to identify, become familiar with the etiologies, diagnostic tests, management, and available, like with any other condition. So what is a floppy infant? An infant who refers to children with hypotonia, which occurs most commonly during the fetal and the early neonatal period. I just want to tell you that when you are examining a baby, this is a newborn baby. So this is the normal posture that you should expect in a newborn baby. And so the arms are flexed, the legs are flexed, and so pretty much the baby is curled up like in utero. So when we are looking at a baby with hypotonia, of course we have to have the history and the genetic history, whether there was babies with similar condition, what was the age at which it started, what were the fetal movements like, whether there was excessive fluids or less fluids. And then the baby, whether there are contractures, dislocated hips is very important. And then of course there is paucity of the movements of the arms and legs. The appearance of the child, whether he's active, alert, or cognitively seems lethargic or irritable, slow. And then various examinations which we will go forward with. This is basically what a frog leg position looks like, and this is classic for a hypotonic. If you can abduct completely a newborn, term newborn, then that is not normal. So if it's a preterm, then you want to know the gestational age of the child, whether sometimes you can err by not knowing whether this child was a pretermer, and then there would be abduction, and you can do the Dubovitz, early Dubovitz criteria on that child. But a term newborn should not have abducted hips, and furthermore, a 3-month-old should not have it. Sorry, I don't know what is happening. Okay, so this is another maneuver which we all know as neonatologists, pediatricians, the scarf sign, where you take the arm and you fold it across the shoulder, and you put one hand on your elbow and the other on the shoulder, and then you see whether the elbow gets across the midline, and normally it should not cross the midline. The traction response we all know, and these are signs on how to examine for a floppy infant. You pull the child up, the head should come up to at least midline for a few seconds, even in the newborn. And then the horizontal suspension, the pictures are very clear. What I say normally is that अगर आपने बच्चे को उठाया और अगर आपको ये सोचना है कि आपके पास काश 4 हाथ होते या 8 हाथ होते, that means you need so many more arms to sort of stabilize the baby is definitely hypotonic. Or if you imagine your dupatta falling over like this, and therefore there is no tone in the axis of that child is hypotonic. Okay? Now when you are trying to localize, okay, now so you said this is hypotonic. What is the problem? So you either say कि central है या peripheral है, ठीक है? Anatomy. And when you are saying central, of course, is the brain or the spinal cord. And when you are saying peripheral, so if you look at the diagram, it's the anterior horn cell, it's the nerve, which can be the axon or the peripheral myelin, or it's the muscle or the neuromuscular junction. So anything which affects the anterior horn cell to the nerve, this is complete a motor neuron. So anything which affects the motor neuron unit. Now, what are the things that you look for if you think that this is central? So affects the higher mental function, like we say, lethargy and seizures. So if there are seizures, it's definitely not only the peripheral. So I'm saying not only, because there are certain conditions where you have both. So mitochondrial disorders predominantly would have both. You can have dysmorphic features, and fisting of the hands is very important. So a normal baby has their hands closed, right? But if you have this kind of a posture, which is cortical fisting, then you know that there is something central going on. And this particularly should not be there beyond 3 months of age. Even the hands should open beyond 3 months of age. So if they're not opening, then you know that there is a problem. Then, of course, the newborn reflexes, which is your Landau, and which is your parachute response, and your gallant, and so on and so forth, suck response, they all will be slow in a central cause. The reflexes will be brisk, and you will see scissoring of the legs. When you hold the baby up in vertical suspension, the legs will cross over because of the adductor spasm. So this is central. So the commonest cause that, we should think about are chromosomal disorders, and the classic for that is Prader-Willi. There is deletion and dislocation that is happening of the translocation of the chromosome 15, and usually transmitted by the father, but there will be some decreased fetal moments. Classically, this actually Prader-Willi is picked up a little later because of the facial features, obesity, hypogonadism, and so on and so forth. But in the newborn, we need to consider this if it's a child which sometimes they have a previous history. So you need to think about this. Then the other commonest central cause is the Zellweger, which is a peroxisomal disorder, and we all know that peroxisomes help in the catabolism of the VLCFA and pipercholic acid. So these conditions are actually diagnosed by doing the serum very low chain fatty acids and the pipercholic acid in the urine. So that would be diagnostic, and they have a classic picture which we are all as neurologists very familiar. They look like Down syndrome. They have the epicanthic folds, they have hypertelorism, but they have a very wide anterior fontanelle, which is like a pear-shaped head. They have hepatosplenomegaly, which Down syndrome do not have. Now, one other thing that you also need to think about is, in a hypotonic child, is the Down syndrome. So Down syndrome is the other common chromosomal disorder that you may have. Now, there are certain conditions. Then if you come down the spine, the spinal injuries are the most common. And spinal injuries would give rise to either paraplegias, and the cognitive status should normally be okay. Commonly, this is because of the delivery, and the babies get stuck, hypoxic. So in fact, you will have both sometimes. So an Erb's palsy may be hypoxic also. And so the baby may have neurological symptoms like seizures, and then the arm may be limp, and you don't know whether it's actually a stroke that is causing this, or it is a lower motor neuron. So examination would be very important. If you get absent reflexes, then that may indicate early stage, or if the reflexes are brisk, then you indicate it's a central cause. Then you come to the motor unit disorders, and when you are talking about the motor unit, the floppy infant, the most important are absent tendon reflexes, and occasionally, if the anterior horn cells are affected, then what we call fasciculations. Because of the time, I'm not going to show you, but it is very important to look at the tongue in babies. If the tongue shows a shimmery sort of an effect, then it is almost diagnostic of an anterior horn cell. Now, because we are in a polio endemic country, we can't say whether this is bulbar polio, because we see that also in newborn, in a 3-month-old baby, or it is spinal muscular atrophy. So therefore, this falls into your classic AFP. You have to report this. Whether you are sure nahi ye to floppy infant hai or ye probably SMA hai, this is to be reported. I cannot emphasize this, that any condition that you are even slightly unsure about, please report it. Because AFP we have to get rid of in the near future, hopefully in the next 3-4 years. So fasciculations would be there both in bulbar polio as well as in anterior horn cell, which is the commonest neuromuscular disorder which presents in the early newborn period. So what are the clues that they will have? So we did all this. The arms will not be moving, lying limp, but the baby is very alert. And they are and they will follow and track you, but there is hardly any movement. And the traction response will be, the head lag will be there, and so on and so forth. DTRs are absent, and as I said, you have to check the tongue. In all floppy babies, if you don't check the tongue, for those of you who are appearing in pediatric neurology, you will fail. So this is what is spinal muscular, and I'm going to go on this a little slowly. Sorry, I'm just checking my timer. Okay. So this basically is what I want to speak about today, because this is the newest thing on the horizon. And we all know it is autosomal recessive. It affects the motor neuron. And I don't know if this works. ये काम करता है? No, it's. ये नहीं, इसके ऊपर नहीं चल रहा. नहीं चल रहा. चले कोई नहीं. Anyway, so basically we discussed the motor neuron. So it's the anterior horn cell, and it can be bulbar also. So remember, if the child has breathing issues, has swallowing issues, then you might think that this is a bulbar type of motor neuron involvement, which is a different genetic condition than SMA, okay? So the baby again will be floppy, but there will be more signs on the face, the gag will be more affected than in SMA. And because it's a degenerative process, initially the baby may be active and may come to you at 3 months of age, and the baby will then be found to be hypotonic. So basically it's genetic, it's the SMN gene. The SMN, it has 2 copies. Onset for the hypotonic floppy infant, we have the infantile form, which we call the Werning-Hoffmann. It's usually fulminating if it presents in the neonatal age and the babies die. But there is now hope on the horizon. And we have new treatments available for this very, very common disorder. And I'm saying common because this is the commonest newborn hypotonic child that we see. And we have sort of, I don't know, Khairunisa would be able to tell me how many cases reported that we have collected, because the AKU does this genetic test, and we've been doing it for the last almost 10-12 years. So we have the data for the country actually of how many cases were positive in suspected hypotonic floppy infants. Now this is the different types. We are more concerned with the 1 and the 2, and so the 1 usually before we had treatment would die before 2 years of age, and then the SMA2 would be variable, and then the 3 would go on to be wheelchair bound much later in the adult life. If we talk about the gene, you have the SMN1 is your functional gene which produces the protein which is responsible for us moving. So when there is a deletion of the SMN1 gene, the SMN2 is not able to work to produce the protein that is required, and therefore the babies are, if you have only 1 copy of the SMN2, then the babies won't survive. So depending on the number of SMN2 copies, the survival or the type of SMA may change. So that's the reason you have to do the genetic testing to find out whether this is early onset neonatal or whether this is the late onset. So if you have 3 copies of the SMN2, then the chances of that individual surviving to have late onset will be better. So we do this in probably siblings of already diagnosed SMN children who have died. And now we can also do antenatal testing so that we can identify the child even before that is born, and sometimes you offer diagnostic or therapeutic abortions, which we used to do before the onset where we got the medication. So if this is, I think, what I was talking about, and so if you have a cross on the SMN1, the SMN2 only produces very little amount of protein. Okay? अब ये नहीं हिल रहा इसमें हिल रहा है जी 2 मिनट और निकल गए अब मैं यहाँ पे उतर जाऊंगी अगर मुझे पर्चियाँ दोगे तो और पर्ची का कल्चर अच्छा नहीं होता है So anyway, so what we have is that, so this is not my fault, this should be deleted. So SMN के 3 medications आए SMA के, all right? One is actually where you give the gene directly. अब चल रहा है? अभी भी नहीं चल रहा है ये नहीं आगे हो रहा है So, 3 treatment available है जो gene therapy है that's it's a very big name, but the common name for the trade name is Zolgensma, and that costs around $2.1 million. Okay, now you will all say, "Oh my God, इसका क्या फायदा हुआ हमें?" मगर this is Novartis which is doing this, and they have because it's just come out in the last 3-4 years, they have a jackpot where you can actually put your patient online and you can be part of that jackpot. So 3 of our patients have actually gotten that injection, and it's an IV injection, 1 dose only, and the child is cured for life. Of course, we are following those children up, but it is a very, very important thing for me to tell you that there are 3 children surviving for the SMN type 1 because of the Zolgensma. ये अभी भी नहीं हो रहा है मैं क्या करूं So anyway, the second drug which is available is Risdiplam, and that comes as Evercity, and Evercity is also available in Pakistan now. It is distributed by Roche, and it comes in a vial, and it is given orally, and so that's easy to give. And but it is also very expensive. This is not a gene, it is actually a RNA splicer. So what it does is increases the SMN2, and therefore you have some protein which is produced. This drug can be used after at any age predominantly, but Zolgensma is nowadays only used for under 2. So you have only 2 years to sort of put your child into that jackpot that you can get. But Evercity you can give for अब हो रहा है अभी भी नहीं हो रहा है Evercity you can give for any age and even the chronic ones, because the SMN2 copies are increased. The cost of that is somewhere. So this is distributed by Roche, and Roche is actually giving us a sort of जैसे एक लो तो एक free. तो ये आप एक खरीदो तो 4 free है खैर उन्होंने मुझे पहले 3 कहा था खैर 4 free है so one of my patients is actually and there is a group which is working with SMA children and they are actually supporting all the children that come to us with a possible need for this Evercity. So Roche is giving it this would अगर वो 4 free दें और अगर के 6 महीने का बच्चा है तो एक वाइल की कॉस्ट आपको महीने की कॉस्ट ₹1,00,000 की पड़ेगी, which is doable, but I don't know how long one can do that for. So this is the second one. The first one which came out was Spinraza, and Spinraza is again given intrathecally repeatedly every 2 weekly. That's not available currently over here. Now I'm going to I'm sorry, but my slide presentations got stuck, so I think I might finish. But one more condition that we need to discuss is the Pompe, and I think we miss the Pompe a lot. It's a glycogen storage disorder where the GAD is deficient, the gene is GAD, and it is acid maltase, which is the enzyme. So nowadays, like in Gaucher's, where you have Genzyme available, Serizyme, this also is one of those where a lysosomal storage disorder where you have enzyme replacement therapy, which tends to improve the output. So okay, it's working now? So this was Zolgensma. So basically this was how you can see what SMA can do. I'm not going to go into polyneuropathies, just one very, very, very rare as a newborn, and the EMG changes that can happen, so basically more for a neurologist to know. This is also important. Sometimes we see a floppy infant and we get the EMG done on that child, which doesn't show anything. Now, congenital myotonic dystrophy will not be picked up in the newborn period by an EMG. So we just need to remember that. This is just a genetic condition. Now, the other thing that we also need to know is the muscular dystrophy, and they will have contractures. So if you have a child who's hypotonic and floppy with contractures, then you think about congenital muscular dystrophies. In this, they will be lethargic, they may be having seizures, and if you see the last one over there, these are the ones which are associated with lissencephaly in the brain. So they are also genetic disorders where if you see a microcephalic with an eye cataract or eye being small, then these are conditions which are muscular dystrophy but associated with lissencephaly. Then you have a whole bunch of myopathies, and which are all genetic. The only important one that we need to know about, and if you're thinking congenital myopathy, then you need to know there are 6 types. You need to know the gene. And I can't tell you enough how important it is to spend on the genetic testing of these children. It's expensive, but it's not non-affordable, let me tell you. So it's around, if you do a whole genome, it costs us $750 US. If you convert it, it's like 1.5 lakh रुपया. अगर आपने इसका EMG कराया, MRI कराया और थोड़े बहुत और टेस्ट करा दिए, 60-70 हज़ार तो आराम से खर्चा हो जाएगा उसका. और ICU में अगर इसको पहुंचा दिया और वेंटिलेट भी कर दिया, तो you will be landing up with 1.5 lakh रुपया. ठीक है? So I think if you are unsure, then it would be better to do a clinical exam and then do a genetic testing. Biopsy is not helpful because we don't have the stains, we don't have anything. Muscle biopsy की अब कोई value नहीं रही है कि हम muscle biopsy कराते फिरें. ठीक है? इसमें सबसे इम्पॉर्टेंट सेंट्रल कोर डिजीज़ है. इसको इसलिए इम्पॉर्टेंट है मिनी कोर एंड सेंट्रल कोर कि अगर ये बच्चे बड़े हो गए, क्योंकि ये हो सकते हैं, ये दे डोंट डाई ऑफ, तो अगर ये एनेस्थीसिया ऐसी मिली तो दे विल डेवलप malignant hyperthermia. That is the important key message that I want to give over here. Next, अब ये फिर फंस गया. एंड देन गॉशर्स की जो पॉम्पे की जो मैं बात कर रही थी, ये GAA म्यूटेशन है, और इसमें फिर ये स्टोरेज के सेल्स आपको नज़र आते हैं, और ऑफ कोर्स यू विल हैव कार्डियोमेगली सबसे कॉमन है. अगर न्यू बॉर्न की कार्डियोमेगली और हाइपोटोनिक फ्लॉपी है, थिंक ऑफ पॉम्पे. And then these are the therapy, the gene replacement therapy they're working on it, it's in process, there are trials, enzyme replacement therapy. देखिए बात ये है कि हम जो है ना ये सोच लेते हैं हमारे वसाइल नहीं है, लेकिन जो ट्रायल्स हो रहे हैं उनमें अगर आप जाएं, वी ऑल हैव आवर फोन्स, उनमें अगर आप जाएं, यू कैन गेट योर पेशेंट रजिस्टर्ड फॉर फ्री. I have sent one of my patients 7 years ago to the US on the firefish study, which was risdiplam for Evercd, and he was completely covered, and he went on the trial. They supported his transport, his stay. So look into options when you're thinking of genetic disorders, of where the treatment, and everything, they are working very fast. Gene therapy is going to be the next answer for a lot of these diseases which hum haath dho ke baithe hue the. Duchenne ki treatment aa gayi hai. Do you know that? So it's, or don't think of it as, oh hum kya kare, hamare paas paise nahi hai. I think we need to look at options. What are the facilities available? Look at donors and then think about it. All right? So, sorry. I think I'm done. I'm not going to go into the neuromuscular disorders. So basically, this is my last slide. When you are doing motor unit disorders, you need to do the CPK, you need to do the EMG, and you need to also check for neuropathies and things like that. So, in short, there is no short cuts to a clinical examination. आप ये सुन के ये ना समझें कि ओ ये तो न्यूरोलॉजिस्ट का काम है, ये मैं कैसे करूँगी. If you can do a good clinical exam, and the things that are important are the condition of the central part, whether the seizures हैं कि नहीं है. आपने उसको ट्रैक्शन कर लिया, फ्लॉप कर लिया, सब कुछ कर लिया, वो फ्लॉपी है. फिर आपको हिस्ट्री पता है, जिन्हें आपको एंटीनेटल पूछना है, मूवमेंट कैसी थी उसकी, अंदरूनी चीज़ थी कि बाहर की चीज़ है, और उसके साथ साथ रिफ्लेक्सेस देखने, फैसिकुलेशन देखना है. बच्चा न्यूबॉर्न सही पैदा हुआ था, 1 महीने बाद आपके पास आया है एज पीडियाट्रिशियन, और आप देख रहे हैं वो फ्लॉपी हो गया है. टंग ज़रूर देखें उसकी, वो देखें कितना इंटेलिजेंटली आपको देख रहा है. अगर वो देख रहा है तो ये ऐसे में है, या पोलियो है, या ऐसे में. ठीक है? सो दैट्स द एंड मैसेज दैट आई वांट टू गिव. थैंक यू.
Thank you, Professor Shahnaz Ibrahim. I think she has already taken a lot of time. We can take up half question per speaker.
So they can all contact me on this email.
Anybody who have any questions?
If you have any questions, thank you.
Today's speaker, because of the shortage of the time, we have limited questions. So please brief your question.
एक्चुअली प्लीज़ देखें 11 बजे हमारा प्लेनरी सेशन भी है, एंट्री ब्रेक भी हमें स्किप करना पड़ेगा. तो मेरा ख्याल है बड़ा ब्रीफली अगर कोई एक आध क्वेश्चन है तो ले लें, क्योंकि हमारे रिस्पेक्टेड स्पीकर्स यहाँ मौजूद हैं. ब्रेक के दौरान भी आप उनसे इंटरेक्ट कर सकते हैं. अगर नहीं है तो फिर हम आगे प्रोसीड करेंगे. हमारे 3 फ्री पेपर्स भी हैं. मेरा ख्याल है फ्री पेपर्स को प्रोसीड करें. अच्छा,
So, as there is no any question,
मैं सिर्फ विद द परमिशन ऑफ चेयर ये कहूँगा, क्योंकि टाइम शॉर्ट था, तो व्हाट आई डिड कि मैंने जो इस हमारी टॉक थी एपिलेप्सी उसके हवाले से और कुछ अदर न्यूरोलॉजिकल इमरजेंसीज के हवाले से एक बुकलेट्स हमारे डिपार्टमेंट कीजिए, तो विद द परमिशन ऑफ चेयर हम उसको ऑडियंस में डिस्ट्रीब्यूट करते हैं अलॉन्ग विद द कीटो बुक.
Sir, with the permission of Dr. Jalal, I would like one question. That you have added the prednisolone tablet in the treatment of the epilepsy. So how much long this treatment could be continued with the anti-epileptic drugs?
जो prednisolone या oral steroids हैं which may be given either in infantile spasm or in drug resistant epilepsy. infantile spasm में जिस तरह के मैंने बताया था कि recently vagabatrin पाकिस्तान में अब रजिस्टर हो गई है VLAP के नाम से. for the past 2 years हम उसको यूज़ भी कर रहे हैं, और उसका जो एक fear factor था peripheral view loss which has not been described in any of the patient. It's fairly safe in 3 to 6 months combo with स्टीरॉइड्स. दूसरी जो स्टीरॉइड की इंडिकेशन है दैट इज इन ड्रग रेजिस्टेंट एपिलेप्सी. जो मेरा जो फार्माकोथेरेपिक वाला दूसरी या तीसरी स्लाइड थी उसमें लिखा हुआ था कि आप IVIG और सोलोमेड्रॉल और ओरल प्रेडनिसोलोन और डेल्टा कॉर्टिल वो ड्रग रेजिस्टेंट में दे सकते हैं इफ़ योर इनिशियल जो ड्रग ऑफ चॉइसेस हैं वेदर वो फर्स्ट लाइन और सेकेंड लाइन है वो कामयाब नहीं हो पाती. ऑन दैट सिनेरियो आप स्टीरॉइड्स दे सकते हैं.
Thank you so much, sir. Now we would like to proceed to free paper presentation, and I would like to remind the panelists about the Young Research Award. So, Yes, and there are only 5 minutes because we are really short of time. So the first presenter is Dr. Farhan Ali, and he's going to present acute disseminated encephalomyelitis in children, experience from a tertiary care hospital.
Okay, so I am going to present my research article on acute disseminated encephalomyelitis. It is an experience from a tertiary care hospital. I have no conflict of interest to disclose. A little bit of the introduction. ADEM is an acute immune-mediated encephalomyelitis. ADEM is an acute immune-mediated demyelinating disorder of the central nervous system that is triggered by a preceding viral or bacterial infection, and that presents with monophasic polyfocal neurological symptoms. So based on the most recent international...
Excuse me. I request the respected audience to please be seated and please listen to the very important and interesting free papers. ये हमें इनको encourage करना है. हमारे young researchers हैं. Please be seated and listen patiently. Thank you.
Okay, so based on the most recent International Pediatric Multiple Sclerosis Society group criteria, a single polyfocal CNS event with encephalopathy ranging from delirium to lethargy, drowsiness or coma, and combined with diffuse poorly demarcated large lesions on the MRI brain, and no new symptoms or signs or MRI findings after 3 months of the acute presentation. So it differentiated from CIS and MS and multiphasic ADEM. Okay. The objective of the study was to determine the clinical pattern, the neurological neuroimaging findings and outcome of the acute disseminated encephalomyelitis in patients admitted in the pediatric department of the tertiary care hospital. It was a retrospective study conducted at the pediatric department of the Aga Khan University Hospital, and it was a 5-year study from January 2016 to December 2020. The inclusion criteria was we included all the children from age 6 months to 18 years and with a diagnosis of ADEM, and we excluded all those children whose MRI findings were not suggestive of ADEM. So after approval from the Hospital Ethical Review Committee, we retrieved the data, and after retrieving the data, 30 children were fulfilling the criteria, and we excluded all others, those were not fulfilling the criteria. So these are typical MRI findings of ADEM, T2 and FLAIR images showing poorly demarcated, diffuse hyperintense lesions. So moving on to the results. So basically 30 patients were admitted with ADEM, and only 1 patient died and 29 survived. Out of 30 we went for CSF in all 30, and 18 out of 30 has normal CSF, while all patients with neuroimaging was showing MRI brain lesions, while MRI spine had also been done. In the majority of the patient it was normal. So most of the patients were female, and the age was ranging from 2 years to 17 years. This is a very important slide, and we find out that the important and most common presenting feature was headache and fever, followed by altered conscious 30% and the seizures 23%. And some patients had visual problems and respiratory problems also. So the MRI brain findings was most of the lesions, like 46% of the lesions were subcortical, and followed by cortical gray matter lesion, which was 40%, and their periventricular lesions, while basal ganglia, thalami were also involved. So the therapeutic approach was tailored based on the clinical presentation. Like most severe presentation, IVIG was used as a first-line therapy, and with a slightly less severe presentation, we went for the methylpred as a first-line therapy. And 6 out of 22 were not responding to methylpred, so we went for IVIG. So if you can see at the chart, 26% of the patient received IVIG as a first line, while 20% of the whole patient received IVIG as a second line therapy. So the length of stay was ranging from 3 days to 12 days, and only 10 patients went to the PICU, and other were treated in the ward. And 4 patients out of 8 patients were ventilated for less than 2 days. So we assessed the outcome at discharge using the MRS score, which was 0 with no symptoms and 5 with severe disability, bedridden and requiring constant nursing care. So the MRS score was quite better, like majority of the patient was falling in MRS score 2 and only 6% patient were falling in MRS 5. So the long-term outcome was assessed by using data from the clinical follow-up, and 22 patients out of 30 were followed, and majority of the patient was showing 68% with no neurological sequelae in the long term, and only 22% of the patient were showing neurological deficit, in which poor school performance was the most common neurological deficit, which was 85.7%, and behavioral issues was the least, which was 14.28%. So concluding my research, clinical pattern of ADEM is variable. Fever and headache was the most common, followed by altered level of conscious, and MRI brain was showing asymmetrical, poorly demarcated diffuse lesions, majority on the subcortical and subcortical white matter. And the clinical outcome in generally was favorable regarding the mode of therapy, whether IVIG or methylpred, and majority of the patients required long-term follow-up for assessing, identification and management of the sequelae. Thank you. Okay.
Thank you, Farhan, for on time. Thank you.
Thank you, Farhan. And now I would like to invite Dr. Mohammad Raza for his presentation on clinical characteristic, treatment modalities, and outcome in hospitalized children with autoimmune encephalitis. Dr. Raza, you have only 5 minutes. Thank you.
Okay, so Assalamu alaikum. I am Dr. Raza and I am fellow in neurology. I will be talking about clinical spectrum, treatment and outcome of children with autoimmune encephalitis. So we chose that topic because you need to know that autoimmune encephalitis is a newly recognized and an evolving disease in the last decade. So that's why data is very much lacking in Pakistan recently. And what is autoimmune encephalitis? So it basically is an immune-mediated encephalopathy which involves the brain parenchyma. And the antibodies are targeted against the specific neuroantigens, and the most common antigen is NMDA, which is called NMDA receptor encephalitis. I think you all might have listened about it, okay? So there are 2 terms, definite autoimmune encephalitis, which is antibody positive, and the probable autoimmune encephalitis, which is antibody negative. So this is the internationally agreed diagnostic criteria for autoimmune or NMDA receptor encephalitis. And the objective of my study was to assess the clinical spectrum, treatment options, and outcome in children with autoimmune encephalitis. Okay? So basically it was a retrospective study conducted at Aga Khan University Hospital in a period of 5 years, and we included children less than or equal to 18 years of age and who fulfilled the diagnostic criteria of autoimmune encephalitis, whether they were antibody positive or negative. And we have excluded the children with CNS infections, metabolic encephalopathy, and drug intoxication. Okay, so we retrieved the data and we analyzed the data for clinical features, investigations, treatment, and outcome, and also assess the results of CSF antibodies. And we also saw the response to treatment and follow-up. So the main outcome of my study was to adapted modified Rankin scale score at 3 months follow-up after discharge. So MRS score is basically a disability score which assesses the patient's ability to carry out their daily life functions, basically. So it ranges from 0, which is a least fever, to the 6 score, which means death, okay? So we categorize patients into 2 groups on the basis of MRS score, and the good outcome was MRS 0 to 2, and the poor outcome was MRS 3 to 6, okay? So these are the results of my study. We had 33 patients with autoimmune encephalitis, and among them 13 were antibody positive and 19 were negative, okay? So among the 13, 12 were NMDA receptor and 1 was anti-Casper antibody. And among the 33 patients, 30 received first-line therapy and 3 received second-line therapy, immunotherapy, and 14 had good outcome and 15 had poor outcome, okay? So 4 patients expired during this study, okay? So regarding the clinical characteristics, so the behavioral changes were very common, including irritability, confusion in 87% of the subjects, and seizures were also very common in 81%, and interestingly, 6 of our patients, they landed in status epilepticus. Okay? Among the movement disorders, chorea was the most common, and psychiatric disturbances are also very common. So 4 patients, they had a preceding history of HSV encephalitis, which was proven on the basis of CSF, and the EEG abnormalities were very common. The most common abnormality was diffuse theta and delta slowing. And the MRI findings were, abnormalities were very common, and we had cortical lesions, white matter lesions, brainstem lesions, and temporal lobe lesions in MRI. 9 of our patients, they required mechanical ventilation, and 16% required plasmapheresis. Okay, so these are the graph shows the distribution of symptoms by age categories, and you can see very clearly that behavioral symptoms are very common, followed by seizures and movement disorders and psychiatric disturbances. And in children less than 5 years, movement disorders were very common. You can see in the blue graph. Okay. So this is the graph which is showing the treatment details of our therapy, immunotherapy. So patient received first-line immunotherapy in the form of methylprednisone or either IVIG, or combination therapy in the form of methylpred plus IVIG. And we divided the response into complete response, partial response, and no response. Okay? So you can see that patients who received combined therapy with methylpred plus IVIG, they have a marked response to immunotherapy, and you can see that 6 patients, they had complete response to immunotherapy, and 3 patients, they had partial response, means they had good response to immunotherapy. Okay, so these we compared the groups with good outcome and poor outcome, and the p-value was significant for response to immunotherapy, means that those who were in the good outcome group, they responded very well to first-line immunotherapy as compared to the poor outcome group. And those who needed plasmapheresis, they all were in the poor outcome group, and the p-value was significant. Okay. So we did the regression analysis to analyze the risk factors for the poor outcome for a study. So we got to know that children between 5 to 10 years of age, they have low risk of having poor MRS score at 3 months follow-up as compared to other age groups. So means they have a protective factor. It's a protective factor 5 to 10 years in this age group. So I conclude my study with that MRI brain can be normal in autoimmune encephalitis, and response to first-line immunotherapy indicates good outcome, and combined immunotherapy with steroids plus IVIG showed good response in our study as compared to individualized therapy. And age 5 to 10 years is a protective factor for good outcome. And anti-Casper antibody patient who was a single patient, but he had a grave prognosis. And so my take-home message for this study for the juniors is that, so whenever you have encephalitis, so it's not necessarily that it's meningoencephalitis or viral encephalitis. If the child is having behavioral symptoms, movement disorders, abnormal psychiatric behavior, so you need to consider autoimmune encephalitis, because early recognition and treatment are imperative to improve outcome. Thank you.
Thank you so much, Raza. Now the next presentation is by Dr. Ambreen Aslam, and her topic is experience of therapeutic plasma exchange in pediatric neurological disorder.
Assalamu alaikum. I am Dr. Ambreen Aslam, Fellow Pediatric Intensive Care Unit at the Children's Hospital and the University of Child Health Sciences, Lahore. I am here to share the experience of therapeutic plasma exchange in pediatric neurological disorders. Therapeutic plasma exchange is removal of the patient plasma and replacement with the donor plasma. The purpose is to remove the causing agent like antibody, toxin, or plasma protein that is causing the clinical manifestations. It is used in neurological disorders like acute and chronic inflammatory demyelinating polyneuropathy, myasthenia gravis, and other neurological disorders. ये आगे नहीं move कर रहा. Objective is to evaluate therapeutic plasma exchange as primary therapy or second line adjunct to other initial therapies in pediatric neurological disorders. It was an interventional study conducted in Pediatric Intensive Care Unit in collaboration with Neuro and Hematology Department from January 2020 till July 2021. All those patients with pediatric neurological disorders were included in the study, and they were either plasmapheresis was used as first line, or those in those patients in which there was no response from the first line therapy. And patients weighing more than 10 kg and hemodynamically stable patients were included. Those patients who refused to give consent were excluded from the study. Procedure was, ये pointer नहीं चल रहा. It was performed using Fresenius Kabi apheresis machine, and plasma was removed at 40 to 80 ml per kg, and it was replaced with FFPs. This is the circuit diagram showing removal of the blood, and then cells and plasma are separated. Plasma is removed, and donor plasma along with the cells, they are reconstituted to the patients. Vital monitoring was done every 15 to 20 minutes, and pre and post plasmapheresis labs were done. 5 to 10 sessions were done on alternate days, depending upon the severity of the illness. Outcome was measured as weaning from mechanical ventilation as well as improvement in the neurological status of the patient using scoring system like GMFCS scoring system and modified research council scoring system. In MRCSS scoring system, 3 muscles of the upper limb and 3 muscles of the lower limb, their power was categorized from 0 to 5 with total score of 60, and improvement in more than 10 points on initial and 48 hours after the plasmapheresis was considered significant. After written informed consent, data was collected on pre-designed performa and analyzed using SPSS variant 25. Quantitative variables were categorized as mean and standard deviation, and qualitative as frequency and percentage. Chi-square was used to find out the p-value. 121 procedures were done on 24 patients, and the mean age was 7.8 plus minus 3.6 years. Mean hospital stay was 41 plus minus 14 days. And 54% patients were of male and 46% were females. Regarding the neurological disorders, 62% patients had GBS, 20 patients had NMO spectrum disorders, 8.3% had autoimmune and CIDP as well. And 45.8% patients had acute motor axonal polyneuropathy as the most common EMG NCS finding, followed by AMSAN, demyelinating polyneuropathy, and CIDP. All of them were 8.3%. And in only 16.7% patients, they had the procedure done within 2 weeks of the start of the illness. Regarding the improvement, 62% patients were ventilated, and all of them were successfully weaned from the mechanical ventilation. And regarding the improvement in neurological status, 100% of the patients with autoimmune encephalitis, they completely recovered from the illness, followed by 60% in NMO spectrum disorder, 53% in GBS, and 50% in CIDP. And all of these scoring systems were clinically significant, that is, p-value was less than 0.05. Regarding the complication during the procedure, 68% patients developed complications, and the most common complication was hypotension, followed by allergic reaction and fever, and all of these were 38, 21, and 7.5% respectively. All of these complications were managed effectively without any mortality during the procedure. Now, regarding the conclusion, therapeutic plasma exchange is safe and effective alternative to expensive first-line therapies like IVIG in pediatric neurological disorders, especially in resource-limited countries. Thank you. Any questions?
Thank you so much, Ambreen. And now we would like to conclude our session, and also we will proceed to the distribution of shields and certificate. I would like to invite Professor Khurshid Abbasi. Sir, please come on stage. Thank you so much, sir. The first shield is for the speaker or valuable speaker, and it is for Professor Shahnaz Ibrahim. Ma'am, please. Thank you so much, sir. Thank you so much, ma'am. Now, I would like to invite Dr. Jalal Akbar to please come on stage to present the shield to the speaker. And the next speaker shield is for Professor Tipu Sultan, sir. Please come on stage. Thank you so much. Thank you so much, sir. Thank you so much, sir. And now I would like to invite Dr. Premchand and Dr. Shazia Sumro, please come on stage and present the shield to last but not the least speaker, Dr. Shazia Kulsum Nashari. And now I would like to invite Dr. Tipu Sultan and Madam Shahnaz, please come on stage. And now the next shield is for the panelist. Thank you so much, sir. Thank you so much, ma'am. And I would like to request Dr. Professor Khurshid Abbasi, sir, please come on stage to get your shield. Pictures, huh? Our next dedicated panelist is Professor Jalal Akbar, sir, please. Dr. Premchand, sir, please come on stage to receive your shield. And Dr. Shazia Sumro, also one of our panelists. Last. And I would request Professor Jalal Akbar and also Professor Khurshid Abbasi. Sir, Madam, you please stay on stage for the Young Research Award. If you have decided.
Dr. Sadaf, यहीं पे अनाउंस कर दें या वहाँ पे आ जाएं?
सर यहाँ पर आ जाएं. ये
we have unanimously decided, all the panelists, that Dr. Mohammad Raza is the best. Please give him a big hand.
Congratulations, Raza.
Congratulations, bhai.
So, yes.
Thank you. It's first time हमने PPA ने इस डिसाइड किया कि इस कॉन्फ्रेंस में हम अपने यंग रिसर्चर्स को इनकरेज करने के लिए उन्हें कैश अवार्ड भी देंगे 10,000 रुपीस का, और एक शील्ड भी देंगे, और ये हर सेशन में होगा. एंड दिस इज जस्ट टू इनकरेज आवर यंग रिसर्चर्स कि हमें सामने आए और हम लोगों को रिप्लेस करें. वो कैश भी है. मैडम आप आइए ना, आप कहाँ जा रही हैं मैडम? ये लिफाफा मैडम से देना.
अच्छा अच्छा ठीक है. ओके ओके.
थैंक यू.
लिफाफा और पर्ची वाली टमाटर को बहुत
Thank you, thank you.
Thank you. And sir, the last shield is for the moderator. So I'm announcing for myself.
जी. Thank you so much, Sadaf. You moderate the session very well, and she's my colleague and faculty of pediatric neurology at NICH. आ जाए खैर में सब. Our young researcher, please, Dr. Raza, Dr. Farhan, आइए. Dr. Amber.
Thank you, everyone. Tea is served at the pool side area. Thank you. केड़ा वाला सर? पेपर वाला presentation.
एक और
बस वो रजा को मिल गया ना, उसी का ये रजा है. रजा
ट्री है ना वो नहीं है
रजा.